We're at the 2017 ASCO meeting here, and I'd like to take a moment to describe one of the sessions we had on relapsed and refractory multiple myeloma. Particularly, I wanted to describe, are all relapses the same and when do we treat? This was part of a session that we had on Friday, and it went really well. We'd like to summarize what we said in that session, particularly for my part. We discussed that there are definitions of relapse and progression, and it's very important to evaluate a patient fully with a bone marrow biopsy as well as imaging if possible to understand if the patient has relapsed and or progressed. Although there are some numerical criteria for relapse, which include reappearance of an M protein or a urine Bence-Jones protein on electrophoresis, there are also some clinical reasons that you may relapse, which would include any of the CRAB criteria: hypercalcemia, renal insufficiency, anemia, or bone lesions, or increasing plasmacytomas. Similarly, for progression, there's also a numeric way that you could progress, which would be basically a 25% increase in your serum or urine protein with absolute values of 0.5 grams per deciliter or 200 milligrams in 24 hours for your UPEP. But there are also clinical reasons that you would progress, again, regarding CRAB criteria or worsening plasmacytomas or perhaps hyperviscosity. With this in mind, we really tried to nail down what the differences are between biochemical progression and clinical progression and what instances should you treat. Clinically, with any end organ damage, you would want to treat. That was not argued upon. But things that were up for discussion were at what point would you treat for biochemical relapse or progression. And I brought up the point that it is sort of agreed that if you have significant biochemical progression, which would be at least 1 gram per deciliter of your M protein, or absolute value of 500 milligrams increase in Bence-Jones, or 200 milligrams per liter of light chain increase, these would be a guidance that the patient needs treatment even in absence of a clinical manifestation. But there are symptoms and times where you may consider treating before all of this happens. This would be, for example, if you know a patient has high-risk disease, for example, high-risk cytogenetics, or if you know that the patient previously had very clinically significant disease at presentation, such that they had end organ damage upon diagnosis. For example, those patients that came in renal failure and you know that they're at risk for having that and you want to prevent that. Another possibility would be that patients have a short treatment-free interval and you know that they're prone to aggressive relapses. This would be another reason why you may consider treating before these criteria that we talked about are met. With that in mind, there's also times where you may consider not treating someone, and this would be related to performance status. Sometimes it doesn't make sense to treat if you don't think that the patient can handle it. These were amongst the few topics that we talked about at that session. There were also others, but regarding relapsed myeloma and progressive myeloma, we were at least able to cover these aspects of disease. Thank you very much.